Diabetes mellitus type 2. What is diabetes mellitus type 2? Type 2 diabetes mellitus is a condition in which the body fails to metabolize glucose, sugar, correctly. This causes levels of sugar in the blood to increase, a state known as hyperglycaemia. When a person does not have diabetes, a gland called the pancreas produces and secretes a hormone called insulin. The hormone is used by the body's tissues to metabolize glucose. Usually the amount of insulin secreted increases in relation to the amount of carbohydrate, sugar, a person consumes. In people with type 2 diabetes, insulin secretion from the pancreas often decreases. This is referred to as reduced insulin secretion. In addition, the body tissues do not respond adequately to the insulin which is produced. Normally the insulin would be used by the body to draw glucose into the cells, where it could be stored as energy which could be used by the body later, e.g. when exercising or any of the other activities which involve energy expenditure. In type 2 diabetes, the glucose is not taken into the cells. This is referred to as insulin resistance. It causes glucose to stay in the bloodstream and hyperglycemia is the result. Type 2 diabetes mellitus was previously called non-insulin dependent diabetes mellitus, NIDDM, and late-onset diabetes mellitus. These names are no longer used because they are inaccurate. Insulin is often used in the management of type 2 diabetes. The condition is increasingly diagnosed in young people. Statistics: almost 1 in 20 Australians, or 1 million people, were diagnosed with type 2 diabetes mellitus in 2008. The actual proportion of Australians with the condition may be higher as many people are not diagnosed until they develop complications, for example diabetic retinopathy. Of those who have been diagnosed with type 2 diabetes, 56% are men and 92% are over 45 years of age. The condition is most common in the Northern Territory where 7.7% of people have been diagnosed with diabetes and least common in the Australian Capital Territory where only 2.4% of people have been diagnosed. It is by far the most common form of diabetes, accounting for 87% of all diabetes mellitus in Australia. Other types of diabetes include type 1 diabetes and gestational diabetes. The proportion of Australians with type 2 diabetes has increased rapidly in the past decade. Estimates suggest that if the increase continues, 3 million Australians will be living with diabetes by 2025. Children: an increasing number of children and adolescents are being diagnosed with type 2 diabetes. Each year, 3 children in every 100,000 aged 10 to 14 years and 8 in every 100,000 aged 15 to 19 years are diagnosed with type 2 diabetes. Risk factors: type 2 diabetes is partly a genetic disease and partly a lifestyle disease. People whose parents had diabetes have a genetic predisposition, meaning they are more likely to get type 2 diabetes themselves. However, characteristics of a person's lifestyle, especially what they eat and how much exercise they do, also influence the risk of type 2 diabetes. People with a genetic predisposition may not develop the condition if they lead a healthy lifestyle. While there is no single cause for developing type 2 diabetes, there are well-known risk factors. Some of these can be changed, avoidable, and some cannot, unavoidable. Unavoidable risk factors: family history of diabetes. People with close relatives that have type 2 diabetes are more likely to get the condition themselves. 1 in 10 of those with a sibling that has type 2 diabetes will develop the condition, as will half of those with an identical twin who is affected by type 2 diabetes. Age. The risk increases as a person gets older. Ethnic background. People from Aboriginal or Torres Strait Islanders, Pacific Islanders, Indian and Chinese ethnic background are more likely to develop type 2 diabetes mellitus. Having polycystic ovarian syndrome or a history of gestational diabetes during pregnancy. Low birth weight is thought to predispose to diabetes due to poor beta cell development and function. Avoidable risk factors: obesity and overweight, physical inactivity, high blood pressure, diet, impaired glucose metabolism. Progression: type 2 diabetes mellitus may have an onset over several months, or be asymptomatic and be detected on a routine blood test. It is generally not recognized and diagnosed until the patient seeks healthcare for another problem. Some common presenting symptoms of type 2 diabetes mellitus include excessive thirst, increased urine output, polyuria, hunger, weight loss or gain. slow healing or frequent infections, blurred vision, dry eyes, headaches, numbness, tingling or burning of the feet, peripheral neuropathy. Without treatment, patients may develop acute complications due to dehydration, HONKC, see below, and long-term complications will develop much more rapidly. The main acute complication is hyperosmolar nonketotic coma, HONKC, sometimes also known as hyperosmolar hyperglycemic nonketotic coma, HHNC. This is a condition that develops over several days in poorly controlled diabetes involving high blood glucose and potentially lethal secondary dehydration and electrolyte disturbances. Long-term complications include microvascular disease, diabetic retinopathy, eye disease, diabetic nephropathy, kidney disease, peripheral neuropathy and autonomic neuropathy, nerve disease, impotence, difficulty maintaining an erection, macrovascular disease, i.e. atherosclerosis, hardening of the arteries, causing coronary artery disease or heart attack, cerebrovascular disease, stroke, peripheral vascular disease, potentially causing gangrene and leading to need for leg or toe amputation. Men are particularly susceptible to diabetic complications and often have higher rates of mortality than females. Symptoms: diabetes can be easily diagnosed if you present with the classic symptoms of thirst, polyuria, passing urine often or waking at night several times to pass urine, nocturia, fatigue, hunger, weight loss. However, many patients with diabetes remain asymptomatic for many years but are still subject to the damaging effects of high blood sugars. Unlike type 1 diabetes, which tends to present acutely, type 2 diabetes presents gradually over several years. At the time of diagnosis of type 2 diabetes, you may already have several complications of the disease, such as heart or eye problems. You may have noticed blurring of your vision, pins and needles in the feet, due to damage to the nerves, and recurrent infections. Diabetes or impaired glucose tolerance may be detected on routine blood tests as part of a general health checkup or investigation for other symptoms or diseases. If you are obese, suffer from high blood pressure, have a family history of diabetes, have high cholesterol or come from a high-risk population, e.g. Aboriginal background, it is important that you get tested for diabetes. Clinical examination: your doctor will perform a careful examination mainly looking for the various complications of diabetes. This will include cardiovascular, neurological and retinal, eye, examinations. In the early stages of disease, your examination may be completely normal. However, as the duration and severity of disease progressed, it is likely you will have some end organ damage. Your doctor will use a special device, called an ophthalmoscope, to look at the back of your eye, retina. Here the doctor may see various degrees of diabetic retinopathy, which basically represents damage to and leaking from the small vessels at the back of your eyes. Often cataracts, white opacities, may also be found in the lens. These develop because the excess sugar upsets the normal consistency of the lens. You may also have dry eyes. Cardiovascular exam may reveal signs of heart failure due to ischemic heart disease. You may have an abnormal heart rhythm or crackles at the base of your lungs from accumulated fluid. In addition, your blood pressure will be checked and your doctor may perform an ECG to detect any obvious ischemic changes. Leg examination may reveal diabetic ulcers, on pressure points in the feet, and peripheral vascular disease, poor peripheral pulses and circulation, diabetic foot disease and trophic skin changes and skin infections. Your doctor will also test the nerves in your legs. You may have the classic glove and stocking neuropathy, which refers to reduced sensation in the distal portions of your limbs, i.e. where gloves and stockings are usually positioned. The neuropathy starts distally and progresses further up the limb as the condition worsens. Your sensations of vibration, tested with a tuning fork placed on the bone, and proprioception, recognition of joint space position, tested by wiggling your toe or finger with your eyes closed, tend to be affected first. In advanced cases, you may have severe pain and impaired motor function. Finally, your doctor may request a urine sample to measure the amount of protein present. This reflects your kidney function, as damaged kidneys tend to leak protein. How is it diagnosed? Type 2 diabetes mellitus is diagnosed when any of the following criteria are reached. Symptoms of diabetes are present, increased urination, increased thirst or weight loss, with a random plasma glucose (RPG) level of greater than 11.0 mmol, L fasting plasma glucose (FPG) greater than 7.0 mmol, L oral glucose tolerance test (OGTT), 2-hour plasma glucose greater than 11.1 mmol, L. Patients who do not reach these criteria may still be classified as having impaired fasting glucose (IFG) or impaired glucose tolerance (IGT) on the basis of fasting blood glucose or oral glucose tolerance test results. These patients are at increased risk of developing type 2 diabetes mellitus. Other tests which may be ordered include glycosylated hemoglobin, HbA1c. This test is not used as a diagnostic or screening test for diabetes but may be used in the ongoing monitoring of diabetes. HbA1c reflects blood glucose levels over the past 2 to 3 months. Results greater than 7% suggest poor blood glucose control and correlate with poor clinical outcomes. When a diagnosis of diabetes mellitus is first made, several tests are often ordered to check for organ function and exclude complications of diabetes. These may include full blood count, urea and electrolytes, potentially showing kidney impairment, urinalysis to check for infection or protein loss through the kidneys, liver function tests, chest X-ray, ECG, blood lipids, including cholesterol. Prognosis: diabetes is associated with a significant long-term risk of early mortality and morbidity. Heart disease, heart attacks 3 to 5 times more likely, peripheral vascular disease, amputation 50 times more likely, and stroke, twice as likely, are the major causes of death in patients over the age of 50. In addition, diabetic eye disease and renal failure due to diabetic nephropathy are important causes of morbidity. In addition, renal failure is potentially fatal. However, several large trials have proven that the risks of long-term complications from diabetes can be reduced with good blood glucose, sugar, control. The acute complication of hyperosmolar non-ketotic coma has a mortality approaching 50% due to the fact that it affects elderly patients with extensive medical problems. Hypoglycemia due to inappropriate use of insulin or as a side effect of medications is also potentially fatal. Thank you for watching the video. Don't forget to like, subscribe to my channel and comment your opinion. Finally, click on the link in the description to support me.